Dr. Hemanth Murthy speaking on vitreoschisis, the hidden danger.
Yeah, good evening. So I would be speaking on vitreoschisis, an unseen danger. Now, we all know the ठीक है? ठीक है? Okay. So we know that vitreoschisis is a lamellar separation of the posterior vitreous cortex, and it's the hidden danger, especially in conditions like high myopia, diabetic vitreous hemorrhage, and traction retinal detachment. Rarely, it is also seen in rhegmatogenous retinal detachment. Now, we assume that rhegmatogenous retinal detachment will have a PVD, that's why they develop the detachment, but you'd be surprised that it is present even in that. This is a video of a patient who had vitreous hemorrhage, and after clearing the hemorrhage, you see everything looks fine, and just looks at a step of laser, but then when I stain it with triamcinolone, you see the posterior cortex remnant present. So you know that there has been vitreoschisis, and if this was left, this would be a scaffold for proliferation and recurrent hemorrhage. So in all patients of vitreous hemorrhage, always try to stain it with triamcinolone. You would come across situations wherein patients have this posterior hyaloid still present. So this was one of the first cases wherein we started observing that this is very frequent, especially in diabetics. So you see the entire posterior cortical remnants being present. And this is at the end of surgery when everything is clear. So we need to recognize, because if we do not remove these cortical remnants, then this would be the scaffold for recurrent hemorrhage. And in retinal detachment, it's a frequent cause of PVR. In high myopia with macular hole detachment, this is also one of the reasons why there is failure of settling the retina. This is a patient of a traction retinal detachment. After removing the tractional proliferation, when I stain it with triamcinolone, you see that the macula has all these cortical remnants. Now, this needs to be removed. We would assume that most of this remnant would be in the posterior pole. No, it's also present in the periphery. Here you can see that I'm removing all the remnants even at the periphery. So if this was left, we know that what would be the problem. Why we see patients with recurrent hemorrhage is one of the reasons is because of this presence of vitreoschisis. So if you remove this cortical remnant, you would probably have a much better chance in seeing that you don't get hemorrhage. In high myopia, it's very frequent. So probably in every case of high myopia, you would see this. So here I've just removed the posterior cortex at the macula. Now we know that at the macula, when you remove the ILM, obviously you'll remove it. But this is not so much as for the macula, but for the periphery, which I will come to. In this video, you will see it. So when you stain, you would see that the periphery has all the cortical layer. The posterior layer is still present. And once you stain it, you would be surprised that all of them have it. So, and you need to go to the periphery. If this is not removed, obviously this would be one reason why retina would fail to attach, because this would contract then and cause a redetachment. So we need to remove this meticulously. I think yesterday in one of the subspecialties, all of that was alluded to, that even the Egyptian surgeons were mentioning that they stain it again and again, even in diabetics, because that's where they see it a lot more frequently. So here you need to stain it, and once we remove this, we even stain the inferior retina, you would see that it is present. So you have to probably stain, restain, and then remove all these. So this would be one reason why, you would have to do it in all these surgeries to make it actually see that you get a good success. Now, this is a patient in which there's a rhegmatogenous retinal detachment, and I started the surgery. I felt, yeah, there is a PVD, but in all these patients, I also stain it again with triamcinolone, and you can see that there is a lot of vitreous still present. So these are all causes of proliferation. So one has to be very careful, and you need to see that we clear this before we So this is where you can make out how it is important even in rhegmatogenous detachment. Now, one of the ways that you can do it also is use the Finis loop. This is a patient of PDR with vitreous hemorrhage, and I've used the Finis loop to initially scrape off this posterior cortical remnants at the macula, and then I use the cutter. Basically, the cutter, because they are so fine these days, one can actually induce the separation of the posterior hyaloid fairly well. And you can, once you get the edge, then it's very easy to do this. Once I have this edge, then one can go forward and you can actually remove it fairly well. So these are a lot of examples which I've shown you just to show you that it's possible to, one second, we go back. And there has been number of studies which have looked into the role of vitreoschisis, and they found that in a study by Van Overdam, he actually did the histopathology study, and he found that vitreoschisis induced cortical remnants was one of the causes of PVR. Similarly, there are various other studies on both diabetics and myopia. So in conclusion, I can say vitreoschisis is seen in a number of retinal conditions, and I think recognition is what is important, as it would prevent failure of your surgery and complications. Thank you.
Dr. Murthy, but do you feel that sometimes you have created breaks in your effort to remove the schisis? Have you created retinal breaks?
No, not at all, not at all. I don't think I've ever, because nowadays the cutters are so precise that you can actually take it out without a problem. I initially felt it's difficult, but I used to use the soft tip cannula so that I don't injure the retina. But then these cutters are marvelous. Actually, once you go finer, that is 25 and 27, you really don't feel the need of using the soft tip cannula.
And sir, do you also try to remove the ILM in these cases, or no, it's not necessary?
I do ILM in the posterior pole. That's what, so I mentioned, we generally remove the ILM. So we are sure that we remove everything. But in the periphery is where the problem lies, which we never, a lot of times it gets missed. So this is just to, make it aware that there is always a problem like this.
So many times this bevel cutter, we can go very close to the surface and able to lift this.
Yeah, it's very easy. I feel it's, once you get the hang of it, you just need to have low suction, and it does work very well.
Sure, sir. Thank you. Thank you very much, sir, for a wonderful presentation.
Even the brilliant blue-green dye can sometimes stain the vitreous.
Can do
But
that.
sometimes it doesn't, and then you have to use...
The triamcinolone is a little better in all this, actually. Thank you.
Thank you so much.
Very good.